Okay, so our third speaker in this session one of improving targeted therapies is Lena Gandhi, who's assistant professor of medicine, associate assistant.
Actually, as an instructor.
You should be an assistant professor at Dana-Farber, and the title of her talk is "Small Cell Lung Cancer: The Next Frontier in Lung Cancer Therapy."
Thank you for the invitation to talk about small cell lung cancer. It's quite a different story, unfortunately, than non-small cell lung cancer, which you heard has had really exciting developments in defining different subsets of the disease. I think this title, which I was given by Bruce, is a good one, The Next Frontier. It's sort of not unexplored, but unsuccessfully explored to date, but I will talk about some of the efforts to try to make inroads. This is my disclosure slide. I will spend my time talking a little bit about the problem of why small cell lung cancer is not like non-small cell lung cancer, and why it's been a difficult cancer to identify really unique drivers of cancer cell growth in. I'll talk about what the limitations of current therapies are, and then focus a little bit on the potential targets and therapies in development, specifically on apoptotic inhibitors and angiogenesis inhibitors, and talk briefly about new potential targets that are still under exploration. So small cell lung cancer is defined as poorly differentiated neuroendocrine carcinoma, not unique to the lung, but over 90% of it occurs within the lung. And unlike non-small cell lung cancer, it's very, very heavily linked to smoking. Over 96% of all cases are associated with heavy smoking. That's true only in about 70% of adenocarcinomas. And to date, small cell lung cancer still comprises about 13 to 15% of all lung cancer. The majority of patients are diagnosed with metastatic or extensive stage disease, which has a very poor outcome, median survival of only 9 to 11 months with therapy, and even amongst patients who are diagnosed with earlier stage disease, the 2-year overall survival is poor. With the changes that have happened with small cell lung cancer do not necessarily relate to therapy, they relate to smoking changes. With decrease in smoking, the incidence of small cell lung cancer has gone down, as well as the proportion of all lung cancer, small cell used to comprise 20 to 25% of all lung cancer, and now is more like 13%, 12 or 13%. There have been management changes, which I won't focus on, that may have made some differences. These are mostly, again, linked to patients with limited stage disease. But prophylactic cranial irradiation is now used in extensive stage patients as well, with some survival impact. Albeit small, there is a push now more towards using surgery in early stage disease, and there are newer chemotherapeutic agents that may or may not make survival differences. There are ongoing trials to address that. As yet, we haven't really seen a clear improvement in outcome, which is, I think, demonstrated well here. This is a recent study from 2009 looking at the outcome of extensive stage small cell lung cancer from phase 3 trials over the last 27 years, and you can see it's not a line that's going in a really great direction. So why is small cell lung cancer so hard to make therapeutic impact in? A lot of that is felt to be related to its smoking relationship. Smoke contains over 60 carcinogens. There's a much higher relationship to smoking in small cell lung cancer. And many of the changes, and then there have been unique sort of abnormalities identified in small cell lung cancer, but many of them are concurrent, not mutually exclusive. And many of them occur in the setting of really significant genomic instability and aneuploidy. And I'll come back to a few of these later, specifically BCL2 overexpression. But aneuploidy does make small cell lung cancer a good target for chemotherapy, since chemotherapy and cytotoxic agents affecting DNA replication do have potential to be effective in exactly that circumstance. And that is really the only effective therapy to date for small cell lung cancer, which is platinum-based therapy. Response rates are high, close to 80% in many cases, which is different than non-small cell lung cancer, which has a much lower overall response rate to chemotherapy. The problem really becomes that development of resistance to chemotherapy is very high, universal when patients are diagnosed with extensive stage disease, and the response to second-line therapies is very low. There's really only one approved agent, only for chemotherapy-sensitive patients, which are defined as patients who don't relapse until at least 60 days after first-line therapy, which shows you just how low our bar is. Response rates for patients who relapse earlier than that, which is a fair number, is very limited. The only inroad that I will just mention, and I won't spend a lot of time on it, that has been made is in newer chemotherapeutic agents. Amrubicin, which is now an approved agent in Japan, has had significantly higher response rates in relapsed patients, both chemosensitive and chemorefractory patients. Its effects on survival remain to be determined. There's an ongoing phase 3 trial to address that now. But to give you an example, in a randomized trial, the response rate in refractory patients was 0% to topotecan in that particular trial, but 17% to amrubicin. The mechanisms of resistance may be, and is really a low-hanging fruit as a target to try to make a difference when people develop resistance to first-line therapy. The mechanism of resistance is not necessarily drug-specific in any way, which also makes it maybe a more broad-based target. A lot of the resistance is thought to be related to upregulation of multi-drug resistance efflux pumps, as well as upregulation of anti-apoptotic factors, specifically BCL2. There has been a trial of an MDR inhibitor, which didn't show much difference. It was sort of a limited trial. The effects on actual MDR inhibition were limited, but there hasn't been a lot of exploration of this mechanism of resistance. There has been a lot of focus, though, on targeting apoptosis in small cell lung cancer, particularly with targeting BCL2, as it's known to be overexpressed. BCL2, in fact, has been shown to be overexpressed more predominantly in tumors that are analyzed post-chemotherapy resistance and cell lines that were derived from patients post-developing chemotherapy resistance. It also is seen to be upregulated when you in vitro generate resistant cell lines. The first drug to look at BCL2 inhibition was an antisense RNA molecule, oblomericin, which didn't go very far, and a lot of this was related to probably the fact that it didn't downregulate the BCL2 very well. I will focus specifically on two drugs that are in current development, navitoclax and obataclax, and I will mention HSP90 inhibitors because HSP90 also may be something that plays a unique role in apoptosis in small cell lung cancer. Obataclax and navitoclax are both inhibitors of the BCL family, which are anti-apoptotic regulators because they really interfere with downstream activators of apoptosis by virtue of differential interaction with upstream regulators of the BCL family. You can see from this that there's pretty significant differences between navitoclax, ABT263, and obataclax, GX15. ABT263 is a much more potent BCL2 inhibitor. It's more potent than any of the drugs here in this class. But there's one notable difference here, which is that it really doesn't inhibit MCL1 very well compared to how well it inhibits BCL2 or BCL-XL. Obataclax, on the other hand, much less potent, but kind of more across the board. It actually inhibits MCL1, if anything, better than the BCL2. It's become significant. I'll tell you in a little bit of why I think that is significant. But navitoclax and its parent molecule, ABT737, generated a lot of excitement because it was shown to really, in a broad way, inhibit a lot of small cell lung cancer models, xenograft models, cell line models. But you can see even from these early data that there's a lot of differential in how well it inhibits those cell lines. Some are very sensitive, some are really completely resistant, and the same goes for the xenografts. And a phase 1 study that we published last year, which was actually a phase 1 study for all solid tumors, but there was a focus in small cell patients, you can see that there was some interest in really taking this forward because at the higher dose levels, we were starting to see activity of regressions and even a sustained partial response. There have actually been 2 sustained partial response now that are still sustained. Unfortunately, the phase 2 trial, which is now also completed and has been presented, didn't look a lot different than this. So we hope that when we finally got to the phase 2 dose and then we focused on small cell lung cancer, that we'd see a lot more activity than this waterfall plot and that you see a shifting over here. We didn't really see that. We saw, again, basically one partial response that's been sustained, some minor regression, some stable disease, but not more activity than this. And the good thing about those trials is that they did point to some reasons as to why that may be the case. Biomarkers of response and resistance were focused on in the trials, but they've also been focused on in preclinical studies. One of the things that I think was was important from the trials is actually showing that BCL2 amplification, which is the mechanism, the drugs act directly on BCL2, knowing that that is actually present in the small cell lung cancer cell lines is important. And it's not universal, and it's been quite variable in multiple studies. But pro-GRP, which is a plasma secreted peptide from small cell lung cancer cells, it's been looked at as a biomarker for small cell lung cancer for many years without much success. But more recently was identified to actually be co-amplified with BCL2 on the same chromosome. So it really is very highly linked to BCL2 amplification. And in this phase 1 study and in the phase 2 as well, we showed that there was a very high correlation between serum plasma pro-GRP and BCL2 copy number. So it was a very good surrogate marker and easy to test marker of BCL2 amplification. It also, although not as robustly, actually correlated with best tumor change. So it also may be a direct marker of response. And the future trials, we hope, will really incorporate a more selective population who really clearly have BCL2 amplification to test these drugs in. But even before these trials started, resistance to the drugs was already identified through upregulation of MCL1. So I showed you that panel of small cell lung cancer lines that had variable degrees of response, which looks pretty similar to this. Higher MCL1 expression results in a higher resistance to AB2737, the parent molecule of navitoclax. And you can see that there's almost a sort of inverse relationship between BCL2 expression and MCL1 expression. So there are sort of alternate drivers, perhaps. Blocking MCL1 does sensitize cells to ABT737, and that has been the focus of efforts to move this drug forward. There are specific MCL1 inhibitors, but many chemotherapy agents actually downregulate MCL1. So there has been a push to really focus on combinations with chemotherapy to overcome the MCL1 resistance in many of those samples. Obataclax, though, as I showed you earlier, does have the advantage of actually inhibiting MCL1 as well, although not as potently as navitoclax. This has been tested in phase 1 combinations with both second-line and first-line therapy with significant response rates. It's hard to know what that means because they were in combination with chemotherapy. But a more recent trial was presented at ASCO this year, which was in a randomized phase 2 study comparing first-line chemotherapy with or without obataclax. And I think it was striking that there was at least a trend towards improved progression-free survival and overall survival. And it wasn't really coming from changes per se in response rates, although there was maybe some difference that was not significant, but there was clearly a significant difference in the refractory rate, which is what you would predict for an anti-BCL2 drug, that it's blocking, hopefully, the development of chemotherapy resistance. HSP90 inhibitors are just now being looked at in small cell lung cancers as a potential anti-apoptotic target. They're obviously a class of drugs with a lot of interest in a lot of different tumor types because HSP90 is a chaperone protein for multiple identified mutated oncoproteins, many of which are relevant in non-small cell lung cancer like HER2 and EGFR, BRAF, and ALK. There was a recent study, however, suggesting that inhibition of HSP90 is singularly important in small cell because of widespread apoptosis. There has not been an identified unique target that the protein is acting as a chaperone for, but the apoptosis does appear to occur through intrinsic apoptosis induction. You can see there's caspase induction in all the cell lines that are responsive, and there's also downregulation of AKT and BAD, the interaction factor that would lead to the caspase activation. So limited data, but we have initiated, based on this, a phase 2 trial of STA9090, which is one of the more potent HSP90 inhibitors in clinical development, and there remains to be seen what the results of that will show. But in summary, I think there's some indication that apoptosis is a good target in small cell lung cancer, but it really may be more unique to certain patients who have particular characteristics of apoptosis, BCL2 overexpression, MCL1 overexpression, or even more complicated interactions of BH3 sets. Tony Latai at Dana-Farber is actually working at using BH3 profiling of all of the different BH3 upstream factors to determine sensitivity to these classes of drugs. The navitoclax that I mentioned to you was also limited in its clinical development by its effects on BCL-XL. There was dose-limiting thrombocytopenia that was felt to be a mechanistic action from BCL-XL, so they are now developing a new drug that is much more specific for BCL2. That will be the focus going forward from Abbottsen, which is the developer of that molecule. Abatoclax is now in a phase 3 randomized trial with first-line therapy. HSP90 inhibitors, we'll see what happens with them. I also wanted to briefly discuss angiogenesis as a target in small cell lung cancer because although angiogenesis has been a target for many different tumor types because of angiogenic involvement in metastatic progression and invasion, small cell lung cancer is one of the most highly metastatic cancers. It's a very rapidly moving disease. There's an almost universal incidence of metastasis in this disease, and there's high levels of microvessel density and VEGF expression, especially if you compare it to something like non-small cell lung cancer, both of which are correlated with metastatic progression and poor prognosis. There's a lot of antiangiogenic agents out there. Some of them have been looked at in small cell lung cancer. In relapse disease, there have been several small molecule, newer generation inhibitors looked at. And I think what was striking about these is not that they saw partial responses, they saw very few, but there was a fair, stable disease rate. And although that's not necessarily as meaningful in other cancer types, in small cell lung cancer, the time to progression for most ineffective therapies is about 1 month. So it's really not a cancer that sits still on its own at all. So this stable disease rate does indicate to me that there's some activity of the antiangiogenic inhibitor. We have an ongoing single-agent phase 2 trial of pazopanib, which also, like sunitinib, inhibits PDGF as receptor as well. So we'll see whether that makes more of a difference. Antiangiogenic therapy has been looked at in first-line treatment. They were pretty disappointing first single-arm studies, which didn't show much difference in outcome, but there has been a completed randomized phase 2 study of cisatripside with or without bevacizumab, that's the VEGFR2 antibody Avastin, which did show an improvement in progression-free survival, but not overall survival. And this just shows you those differences in the curves in looking at progression-free survival, but no real difference in overall survival. That's a similar phenomenon that's been seen in other cancers, but again, I think making a difference in stabilizing disease, at least even transiently in small cell, is something we haven't achieved with any other drug to date. There has also been at least one study looking at angiogenic inhibition in maintenance therapy after first-line therapy, which is, we know, sort of the only window where there might be some opportunity to intervene before developing chemotherapy resistance. And although the overall study was negative for limited stage disease, at least, and that's what this graph is for, there was a trend towards improved overall survival, which implies that, that disease stabilization really may make more of a difference when we're using these drugs earlier on in the course of disease. So just in summary, there's this transient disease stabilization, but we don't have an improvement in survival. Whether this is due to them not being very good drugs that are being used, or whether it's due to not targeting all the right things, it's not clear. There has been certainly a lot of preclinical data suggesting that VEGF targeting alone results in more invasive tumors at the time of progression that then progress quite rapidly, and that might be what's going on here as well. I think there certainly is an opportunity to think about more combination therapy with other agents that work in different ways, or even to overcome some of the VEGF inhibition problems with other aspects of angiogenesis, PDGFR, FGFR, TIE2, and maybe upstream regulators of angiogenesis like mTOR, and those are some trials that are on, at least in early preclinical development. I just wanted to mention a few of the other targets out there that have clinical studies. Hedgehog inhibitors have been a developing drug molecule that's of interest in basal cell carcinoma, so they're going forward and finally going to be able to go forward in small cell lung cancer. This is a study from 2003 showing that Hedgehog signaling may be important in small cell lung cancer beyond stem cells, but important in cell line models and in mouse models in general. And it's never been taken forward beyond this initial observation, which showed specifically in small cell lines that Hedgehog signaling inhibition with a cyclopamine, or an analog of an inhibitor of smooth end, results in inhibition of proliferation, inhibition of colony formation, and increased apoptosis. There is now just started a phase 2 trial of a molecule from Exelixis and BMS looking at the effects of Hedgehog inhibition in combination with first-line chemotherapy and effect on really progression rate or development of chemotherapy resistance. The certainly people have been trying to do what is done in many other tumor types, which is really to look more specifically for unique targets in small cell. Despite the fact that it's a smoking-related cancer, we now have the ability to look more broadly for targets in a more genome-based way. We also have had actually for some time, a mouse model of small cell lung cancer that was first developed in 2002 by Anton Burns using altered P53 and RB to generate small cell lung tumors that go on to metastasize. This has been modified recently with the addition of P130. It's been a somewhat difficult mouse model to work with because of a very long latency period to development of tumors, but I think that's changing now. This was a recent study published in July looking at whole genome copy number alterations in tumors derived from these mouse models, which re-identified some of the things that have been seen before in small cell lung cancer, MYC amplification. But this paper did focus on a new identification of a recurrent amplification in nuclear factor 1b, which has been demonstrated previously to regulate expression of lung differentiation genes. They went on to show that it's also amplified in some small lung cancer cell lines and is oncogenic under certain conditions. So this may be a new target to look at more closely in clinical development as well. I think this was sort of a seminal paper which shows you both the problem and maybe potential solutions of small cell lung cancer. But this was a study which was published in Nature last year, which sequenced the entire genome of a small cell lung cancer line in comparison to a matched lymphoblastoid cell line from the same patient, and identified all the abnormalities. So 22,910 somatically acquired substitutions were identified. The majority of these were really G to T transversions, indicating again that there's a lot of smoking-related changes, but there were more unique changes seen as well. In this paper, they focused on one change that was seen in CHD7, a chromatin remodeling agent, which was amplified in this cell line that they looked at, also amplified in 2 other cell lines, and overexpressed when they looked in primary patient samples in tumors. So again, might be a target. Both of these things I've shown you seem to correlate with MYC amplification, so I don't know how unique of targets they will really be, but Kwok Wong's laboratory has made a mouse model of CHD7 activation, which will hopefully be a good way to really test how much of a unique target this is. So just in summary, within there's a sea of smoking-related changes, but there may be more unique drivers of tumor growth that we still have to tease out. There are certainly broad categories of mechanisms of chemotherapy resistance that I think are good targets, especially since there may be really good biomarkers now to identify patients who will likely respond to anti-apoptotic therapy. But a lot of this is still in a much earlier stage, unfortunately, than non-small cell lung cancer. Thank you.
Thank you for an excellent talk. Really great. Any questions from the audience? Maybe I'll just start and ask, is there any role for PI3K, AKT inhibitors in this disease?
I mean, it's a good question. There haven't been phase 2 focuses on this. There have been handfuls of small cell lung cancer patients on the phase 1 trials of PI3 kinase inhibitors without response. I don't know still how meaningful it will be. Many of the responses, for instance, in non-small cell lung cancer to phase 1 agents that have been in development have not been mutation specific. I think now we're getting better PI3 kinase inhibitors that may be really more driven by mutations, so I think that will be an opportunity to look at small cell as well.
And is there experimental data demonstrating that these cells are dependent on MYC? Or if you silence MYC, do they?
So not necessarily. In some cell lines, yes, but broadly, considering that MYC is amplified in 20 or sometimes more %, I think part of the problem is that there are other alterations. It's not necessarily always a unique driver.
2 questions about BCL2. Do you have any pharmacodynamic data for how well you're inhibiting the complex? That's the first. And the second, it has never made sense to me that they give the drug every day, especially in combination with chemotherapy. It would seem to me that the toxicity, as I understand, is in part thrombocytopenia when you give it every day. The logic of giving the therapy is enhancing apoptosis, especially when you give cytotoxics. Why don't they give it in a pulse with the cytotoxics?
It is actually given in a pulse. So those combination therapies, at least with the combination therapy that's ongoing with navitoclax, is given in a pulse. It's given. It's a phase 1 trial that hasn't been actually presented, but I'll say the design of the trial was actually 3 different schedules of either starting the day before chemotherapy, starting the day after, but a 3-day pulse with exactly that goal in mind, that there's no clear role, especially with the thrombocytopenia, to do that. Obatiquax was different because it doesn't have that BCL-XL, it doesn't have much inhibition of BCL-XL, so it never had thrombocytopenia and neutropenia as a dose-limiting factor. I don't think that they had data as to why they should be dosing it every day, but it was done because it could be.
Is the dose that you can give as a pulse, is it higher than the dose you can give every day? And do they have any measure of how well they're inhibiting the complex?
There is not, to my knowledge, any measure for either drug of how well the complex is being inhibited, honestly. But the dose cannot be given higher. Actually, there has been dose-limiting neutropenia in the combination with navitoclax, which is why it's not going forward. Actually, this more selective BCL2 molecule hopefully will.
I was wondering if you had seen this this correlation between BCL2 levels and the pro-GRP in the blood. Was there any correlation between GRP levels in the blood and clinical benefit to any of the Abbott compound, Abbott 263?
Yeah, I'm sorry, that was one of the slides, but there was a correlation, maybe I can get back to it, between best tumor response and pro-GRP levels.
Oh, I'm sorry.
So it was, not as robust of a correlation, but this is the best tumor change. I'm sorry, but best tumor change, meaning those who actually had. So that was both correlated with increasing levels for progression as well as in both directions, actually. It was a fairly good marker for response.
Other questions? Bruce?
Lena, there are small cell tumors arising in a lot of different places, not very common tumors, but they look the same. Do they have the same gene expression profile, or do we know anything? I mean, is it really the same tumor when you find it in the gut or the bladder or the...
Yeah, there's somewhat limited data, but the studies that have looked, they look pretty similar. There's certainly the RBP53 similarities that they all have that. There has been MYC amplification seen. Some of the other things haven't been looked at, really, honestly. But morphologically and clinically, it also behaves very similarly. I think the one difference might be brain metastasis, which might be a feature of lung cancers.